non-congruent lock in flexion with side flexion to the right, rotation to the left. The slack is then taken up by fine-tuning the rotational motion at L4, L5, and then further movement into the soft tissue barrier may be gained by gently placing the therapist's leg on the patient's left leg. This takes up a little more slack. The technique is then done in the classical fashion with the 4-point contact, doing the movement like that. Under no circumstances must the leg be used to torque on the lumbar spine. It is merely there to explore the last part of the barrier. The cervicothoracic junction is a very important area for total body dysfunction and for regaining function. Lewitt suggests this is the third major area after the craniovertebral and after the lumbosacral junctions. And certainly problems in this area are very much associated with stiff extension positions of the craniovertebral area. So with the excellent techniques of mobilizing in this area and the techniques that are being suggested in the following shots, this will be a very important way of tackling dysfunction in the cervicothoracic junction. This is considered to include the C7, T1, and then T1 to T4. In the event of stiffness into flexion, which is an unlikely scenario, it's probably more stiff into extension of the C7 on T1, but the following techniques would be useful. The C7 facet joint can be engaged with the therapist's left hand, the shoulder is stabilized with the right hand, and a movement in a caudal rotating right position is achieved. This would classify with slight kneading of the muscles as a translatoric massage technique. To gain extension of the C7 on T1, the joint can be taken now into a left rotated position. Previously we were looking at the right side. For the sake of the film, we'll take the opposite rotational position. And now the joint is taken downwards with the hand, and the stabilizing force with the opposite hand will be to bring the shoulder slightly forward. So the effect that is being gained is to take the facet joint down and backwards into a left rotating, extending position. Some prone techniques are also useful. A similar technique to gain flexion with rotation to the left can be achieved by using the hypothenar eminence on the right upper facet joint of C7, T1. The shoulder is stabilized in a slightly dorsal direction, and with the cross hand application, the correct force of rotation to the left in flexion may be achieved. Stabilization of the T1 to T4 can be achieved by holding the ribs and the shoulder girdle stable. This may be achieved in the following fashion. The patient is asked to take the weight on the elbows, and now the technique can be done to mobilize the right facets in a left rotating flexion range. The T1 can be further stabilized by stopping it moving into the flexion left rotation. The joint on the left side can be encouraged to go back. For the sake of the film, this will be assumed to be the gaining of right rotation. This may be achieved by taking the hand onto the facet joint, moving it back into a right rotation extension position, stabilizing the spinous process of T1 to prevent it moving into extension right rotation. Because of the stiffness over many segments, perhaps all 4 segments in this area, and the chronicity of the problem with muscle involvement as well as joint involvement, translatoric massage techniques are important in this area. The following is a useful technique. Sit on it. The patient is asked to place the forehead on the forearms. The therapist takes hold of the individual segments and does a little extension distraction movement. Further mobility can be gained by adding kneading massage. 2 views of this will be shown. The lateral view shows the gaining of slight extension with distraction. A more oblique view will show the gaining of range by doing side bend, rotational movements, coming into the congruent motions of extension of the upper thoracic spine, which behave the same as the cervical spine. And relax. Distraction will be an important technique in this area. And one of the important distraction techniques has been developed by Kaltenborn. We'll have to stop there, Dave, for a second. The Kaltenborn distraction technique is done in the following fashion. Manual therapists may have to modify their body position to achieve the lift which will be in this direction. People that are relatively strong in the arms can probably do it just by a cephalic arm movement. But in the case of female therapists who probably will require a little more thrust from the body, various modifications have been achieved by locking the back into extension and using more of a body lift. The therapist is encouraged to modify this to suit their own body type. The principles of the technique, however, are as follows. The patient is asked to place the hand round the neck, letting the hands come down to the cephalic bone of the segment being moved. It is only possible to achieve this down to about T2. In this particular case, a release of T1, T2 will be achieved. The therapist takes hold of the patient's arms by threading through this position. The patient is then rocked into a slight extension position so that the vertebral joint, the discal part, is kept horizontal to the ground. Then by doing a cephalic lift, the discal joint is distracted and the facet joints are glided in a superior cephalic direction. The technique is to come around to engage the superior bone of the segment to be moved, and the patient is then a little lift in a cephalic direction. Various modifications of this technique can be achieved in the lying position with rotation or without rotation. These will now be demonstrated. To achieve stabilization in the supine lying position, the hand tripod will be used. The transverse processes of the caudal bone of the segment will engage the therapist's middle finger and thenar eminence. The spinous process of the upper bone will go into the space created by the index finger. The patient is slightly turned. It is important when going back into the supine position that the neutrality of the kyphus of this area is maintained, which is done by supporting the head. The technique can then be done as a little distraction or as a slight gapping of both facets with a posterior glide technique. The advantage of doing rotational techniques is to produce a fairly pure separation of the zygapophyseal joint, the facet joint, on the side to which the rotation occurs. This can be achieved by producing rotation in that direction of the cephalic lever, or by applying an impulse to the spinous process of the caudal bone of the segment in the opposite direction, thus creating a relative rotation to the right side. In the particular case being shown at the moment, rotation to the left will be achieved. The impulse will be applied from the right side of the spinous process of T1, relatively rotating it to the right, achieving a left rotation of the cephalic bone, producing gapping of the facet joint of the left side. It is important when doing these techniques to allow mobility to occur in the upper thoracic segments, which means that the shoulder should be free over the end of the bed to free the ribs from basically stabilizing the segment being moved. This is achieved in the following fashion. Rotation of the head to the left can be achieved in flexion, or to get greater locking, in extension. The movement in flexion would be to flex down to, but not to include the joint to be mobilized, to side bend down to, but not to include that joint, and then to go into the barrier by taking up rotation in slight side bend opposite, flexion, which is the non-congruent lock for the neck. To ensure that no torque is applied through the neck, the head is supported on the therapist's thigh. This means that the impulse then will be specific to the spinous process of the caudal bone in the following way. This technique can also be done in extension if slightly more stability is required. It is absolutely essential, however, that the therapist supports the head in this way on their own thigh, and under no circumstances should the technique be done by torquing on the head, particularly in extension, which would be taking it into the dangerous positions for the vertebral artery, and at the very best would be putting major strain on the neck, which is totally unnecessary. The same technique can be done in sitting. Stresses on the neck can be even further reduced by using the sitting position, as this allows a slight distraction to be applied just prior to the thrust from the caudal bone, thus further protecting the neck. The setup will be identical to the side-lying technique. The neck is taken into flexion down to the joint to be moved, and slight reduction of that position will be achieved. Side bend down to, but not including the joint to be mobilized. And then the last of the three movements of rotation will gain the barrier. The neck is supported in that non-congruent position. A very gentle distraction is applied, maintaining the lock, and the impulse is then applied through the thumb, so that the caudal bone is moved relative to the cephalic bone, achieving left rotation. It should always be remembered that the ideal direct gapping of the zygapophyseal joints also tends to close the intervertebral foramen somewhat. So if any difficulty in analyzing the size of the foramen in terms of signs and symptoms is achieved, it would be recommended that the distractive techniques would form the primary technique modality. So let me just the basic tendency for the thoracic spine to stiffen towards kyphosis can be encouraged into more of an extension movement with a translatoric technique developed by Main. The patient's hands are placed behind the neck, and the movement is then done with gentle oscillatory movement, with the therapist's hand lightly pressing and stabilizing the caudal bone. Modifications with side bend and rotation can be achieved. This is a translatoric movement, so any major attempt to stabilize is not made. It is rather more considered important to have a rhythmic movement with input from the mechanoreceptors of the zygapophyseal joints and alterations in the tension of the neuromuscular spindles. And various movements in different directions in a rhythmic way provide a very effective introductory technique to this area. There are two basic positions in which thoracic mobilization and manipulation are achieved. One is the supine position, the other is the prone position. In manual therapy, much more emphasis on developing techniques in the supine position has been done, as it is far more versatile. It is possible to accommodate the kyphus. It's possible to produce distraction within the neutral position of the spine, and it's also possible to gain rotational movements to get zygapophyseal gapping without putting any major stress on the ribs. So this technique, although more difficult to achieve perfection with, is very preferable to the prone positions. The lever arm which is used will be the arms across the patient's body in that fashion, with the arm that is closest to the therapist being placed closest to the patient. This allows some space between the ribs on the opposite side and accommodates rib motion there when this will be the mobilizing force. The hands can also be placed around the patient's neck, thus supporting the patient's neck in that fashion. If the patient has difficulty with putting the hands round the neck, and this position is used, which means that the neck is not supported, a simple strategy is to take a towel. This is placed around the patient's neck and is gripped by the patient with the hands that are placed across the chest. This supports the head perfectly well and augments the therapist's support. The contact on the caudal bone is by the classical tripod of the therapist's hands. This can also be achieved by a wedge. The important aspect of this technique is as the patient is moved into a rotated position, the joint to be manipulated can be reassessed by going into a slight rotation or extension position, and then the transverse process belonging to the spinous process, which has been tender, is contacted. You will remember the 1, 2, 3, 2, 1 rule. The correct transverse processes are engaged. This should be symmetrical on both sides for the bilateral techniques of distraction and gapping. The patient is rolled back over the therapist's hands, maintaining the neutral kyphus. A distractive movement or a posterior glide movement can be achieved. As a manipulation, it would be achieved in that fashion for distraction, at a different joint, taking up the slack, engaging the barrier, and pushing down in a gentle movement at right angles to the zygapophyseal joints, producing a bilateral gapping. If an asymmetrical contact point is used with the transverse process of one vertebra and the transverse process of the caudal vertebra being asymmetrically achieved, a direct pressure through the chest will produce a rotation to the side of the lowest contact point, thus gapping the zygapophyseal joint on that side. This will be achieved in the following manner. The joint is engaged. The asymmetrical contact point is used, in this case using the T6 on the right side with T7 on the left side. The T7 is the lowest contact point, therefore the rotation will take place towards T7. The joint barrier is engaged and a symmetrical thrust through right angles to the facet joint is achieved in that fashion. It is also possible to produce rotation by using a symmetrical contact point over the transverse processes and then producing a rotation of the upper segment. If such a long lever is used, it is very desirable to use a non-congruent lock. And because the thoracic spine is essentially in kyphosis, the non-congruent lock will be achieved in flexion. The patient is re-examined. The symmetrical contact on T7, both sides of the transverse process, is achieved. The patient is taken back into a slightly flexed position. The locking is achieved by side bending to the right, which makes the spine stable for rotation left in flexion, and the movement is now achieved by doing a rotation motion. As a mobilization, this is effective. As a manipulation, it is very effective. In attempting to mobilize the thoracolumbar junction, Once again, the problems of long levers is encountered. It is generally much firmer to use an extension lever, as the zygapophyseal joints are essentially going into much more of an impact position. So non-congruent locking in extension will be more firm than non-congruent lock in flexion. And if the upper lever is being used, this should be taken into an extension position. Utilizing the side bend facility of the table, the patient is taken into side flexion to the left. In extension, the extension is maintained by pulling in a cephalic direction and rotating to the right, which is the non-congruent lock for the upper lever. The lower lever can be placed in a flexion or indeed in an extension lock if more stability is required through the lower lever. This will be left as the classical position in the flexion lock. Contact is made with the thumb on the right side of the cephalic lever. There will be a contact with the therapist's arm through the patient's chest and with the anterior aspect of the patient's chest by the chest of the therapist, so that although this is a long lever, the actual lever being used for the manipulation will be a short lever just over the affected bone. The other hand supports the flexion locking from below. The technique will be to simply go into rotation, to engage the barrier, to ask the patient to gently breathe out, and a little thrust is done from the cephalic lever, trying to restrict the force to the lower part of the chest and the lower part of the thoracic spine, thus preventing the shoulder from being strained. It is possible with larger patients where it is difficult to place the hands right around the patient, just lay down, to use a wedge. The wedge will be placed on the transverse processes with the spinous process of the upper bone being accommodated in the space of the wedge. The lower the wedge, the more important it is to maintain the neutrality of the kyphosis. This will be demonstrated. In the event of attempting a manipulation or mobilization in the low part of the thoracic spine, the wedge is placed on the transverse process of the caudal bone. The kyphosis is supported by moving across the wedge. The barrier is engaged, being careful to ensure that no extension occurs, which is painful, and then the technique can be applied by doing a distraction or by doing a posterior glide manipulation. This is very useful when it is impossible